Hadith Qudsi that for every disease, Allah has created a cure. And there exists a cure for every disease. And I think if we see that really the human body has the ability to cure many different diseases, and we'll go through them as we talk. Hello? Can you hear me?
Request other to mute, please.
All right.
Dr. Nasreen, please mute. Okay, Dr.
All
Nasreen,
right. So, yeah, so this is your typical kind of, I'm going to go through a little bit of the science. This is when you have, of course, a diploid germ cell. So the diploid germ cell has two chromosomal components, one from the mother, one from the father. And then, of course, that goes under meiosis, and then it undergoes a second meiosis. So meiosis 1 and meiosis 2, and then you get 4 gametes. These are the sexual gametes, right? So these are your either spermatozoa or oocytes. And of course, when these combine into a zygote. And then that zygote, of course, so you get that male gamete, female gamete, combining to become a zygote, and a zygote is a fertilized egg, and of course that can become the embryo, and that's part of embryogenesis. And these cells, these embryo cells, of course, have the ability to renew and to become differentiated. So they can become many different type of cells. And this is just color coding just to kind of show you that it starts off as a certain type of cell, and then it can regenerate, and also it can become different types of cells. This is some of the dates in the historical kind of how stem cells came about. They were first identified in 81 in Cambridge University, and then the famous sheep cloning, Dolly the sheep, in 1997 happened. We'll talk about how that and what specific process was. Then in 1998, they started isolating embryonic or human embryonic stem cells, and were able to regrow them in the lab. So getting them and isolating them was possible, but growing them in the lab was something that was difficult initially. Now, there was a controversy in 2001 where President George Bush created a problem in that there was some of the embryonic stem cells were being obtained from either IVF, so from fertilized cells that were produced in IVF labs, or from abortions. And because Bush was kind of on the right-wing kind of side, he was very against abortion, and so he made a law in 2001 that no more embryonic stem cells could be created in the United States from aborted fetuses. Anyways, that's not the point. So we'll talk about Yamanaka. This is very famous, where he talked about induced pluripotent stem cells, or iPSCs. We'll speak about what those are specifically, and then the treatments started in the early 2000s. I was actually involved with stem cells in about 2003 and 4. 5 and 6, where we were doing stem cells we would get from bone marrow or from fat, what we call either lipoaspirate or bone marrow aspirate stem cells, and we would isolate them and then use them, inject them in different areas. We were doing that outside of the US in the Bahamas at that time at a company called Regenex, and also in Panama. And then, of course, spinal cord injury was used using stem cells treatments, blindness, and then other treatments were used with iPSCs in 2014. So these are some of the terms, as we say, the jargon, stem cell jargon. Self-renewal is the ability of cells to regenerate themselves. Totipotent is when a cell can form the whole individual and other parts of the individual, including the placenta. So that's a totipotent cell that can form any part of the cell organism. Pluripotent, it can form all the major cell lineages. So this is your ectoderm, endoderm, and mesoderm lineages. And of course, those lineages can then go into differentiated cells later on. So pluripotent is something that you will hear about, and we'll talk about induced pluripotent later on. Multipotent is a cell that can go into many different differentiations, but it's still limited as far as certain tissues. So for example, the hematopoietic stem cells, or what we call the blood precursor stem cells, they can only become blood cells. Normally, a blood cell cannot become a muscle cell or a cartilaginous producing cell or a chondrocyte. Differentiation is when the cells become differentiated, they can go into their specialized tasks, and they can do specific activities themselves. And of course, regenerative medicine is the field which encompasses the whole of stem cell medicine. So embryonic stem cells come from a 5 to 6 day old embryo, and we'll show some images. And then adult stem cells are the ones that are actually in the adult tissue after birth. So embryonic stem cells are last and last and last. So this is we use the term passage. So when we take a cell and we go through another division, another second division, next second division, it's called a passage. And embryonic stem cells can undergo multiple or endless passages. You can replicate them multiple times. Adult stem cells can undergo limited. So most adult stem cells undergo about 40 to 50 passages at maximum. and after that they stop being able to reproduce. Multipotent, of course, these can go into many different cell layers, cell lines, easy to find, and of course the ethical issues we talked about. These, of course, do not last. They're not multipotent, harder to locate because they're located in different parts of the body. And we'll talk about what parts of the body we can find adult stem cells in. They are all over the body, but they're in very specific locations. So this is what an embryo kind of looks like. Here's the images, and you can see the zygote. That's the initial fertilized egg. And then it becomes a 2-cell, 4-cell, and it goes into the morula, and then it becomes the blastocyst. And that outer side is what becomes the placenta, and the inner side is what becomes the actual embryo itself. So this is from IVF embryos. You can get these cell lines from IVF embryos. So this is one way to get embryonic stem cells. And then you can take these cells and then grow them in a lab and then transplant them in different tissues. So this is how this is a little bit more imaging kind of thing. So this is looking at the blastocyst, which is becoming the fertilized, eventually the embryo. This can be then taken, put on a fibroblast layer, and I'll show you what that fibroblast layer looks like. So they usually have mice fibroblasts. So we grow these cells mostly on these mice fibroblast cells. We can take them and we can take them off once we've grown 2 or 3 bilayers, and we can take them off, we can grow new layers. We can continue growing these layers and establishing them. And then these, of course, cell lines can then be differentiated through different precursors and through different signal transduction proteins. We can then turn them into either airway epithelium, pancreatic beta insulin producing cells, or intestinal cells, or other ones, as we've discussed before, and we'll talk about in more detail. And of course, these can also be then transplanted into humans, either through different ways, either intravenously, direct injections, or even intraarterially, and then delivered to the area where they need to function. So this is what the embryonic stem cells look like. This is the fibroblast mice fibroblast layer. So these are the mice fibroblasts that you see, and these cells are growing on top of that layer. And then these are different tissue proteins that are fluorescent that we can kind of then use to determine which are the embryonic stem cells, what do they look like, what sizes are they, and when can we use them, when can we transport them, and when do we decide that we need to culture some more or take some of these off in culture. So we can see what they look like under an electron microscope or other types of fluorescent microscopes. So what are the different processes we do with stem cells? Well, first, of course, isolating. We talked about isolating certain stem cells and making sure that we got the proper cell, and we use different ways to characterize cells, and cells have different markers on them. The different CD markers are the most common ones. Of course, MHC markers we also talk about, but these are different ways that you can characterize what kind of cell line this will become. And then from those CD markers, you can tell it's going to become a blood cell, it's going to become a chondrocyte, it'll become a cardiac myocyte based on that characterization. Now, tissue expansion or cellular expansion, this is where we start to culture those cells. So we take the cells, put them on that fibroblast layer again, as I was talking about, and we culture cells and increase the number of cell lines that we have, so we can reproduce those cells and produce extra cells, as many as we need. So often in the billions, we can even produce cells, depending on where we've taken them from and how often they can passage. And then differentiation is the ability to take those cells and then turn them into the cells of use. So the different types of functional cells we can then do, and this is where we activate those certain stem cells. Again, using different markers and different proteins and different chemicals, we can take those cell lines and turn them into the cell line that we want specifically. And this is kind of where the original regenerative capacity of cells we talked about from the newts or for amphibians, where if you cut off a limb, the limb is able to regrow into a functional limb. Now that, of course, is a very complex process, and we don't have that ability in our cells, in mammalian cells, if a limb is cut off to regrow the limb. But nonetheless, this is the kind of science behind what we decided that we could do with regenerative capacities of stem cells. And we hope eventually there may be a time that in the future we'll be able to regrow certain organs, certain limbs, and certain other functional parts of the body. And we'll even talk about and show some examples today. Now, in humans, there are different cell lines, and different cell lines have different capacities to regenerate. We know that there's certain tissues, for example, the skin, as shown here, or the intestinal tissue or liver tissue, which is has a very high capacity for regeneration. It can very easily, quickly regenerate. Other tissues have less of a capacity. Muscles and bones are a more mid-level capacity, and then there's other ones which have a much lower capacity. Cardiac cells, chondrocytes, and brain. And this is why in many of these tissues, when there's injury, it doesn't often regrow. You get scar, myocardial scar, you'll get tears in the tissue and you don't get a repair of the tear. And we know that we also get glial scarring in the brain. And so these tissues are more difficult to regenerate, but it doesn't mean that they're impossible to regenerate. And we'll talk about that later on. So where are adult stem cells located? Well, they are located just about in every part of the body. We know in the heart, there's some cardiac stem cells. In the brain, around the glial tissue, on the axons, there are certain cells which are stem cells, which can regenerate. The liver, of course, has many stem cells. The blood vessels and endothelium has many stem cells. Within the pancreas, there are some stem cells. The skin, of course, is one of the ones that can regenerate very fast. Bone marrow and fat is where we normally get stem cells nowadays when we need to culture stem cells. So we will do either what's called, what we used to be called liposuction, but really we do lipoaspirate. Liposuction is a much larger amount of fat taken. We usually take about 30 to 60 mLs of fat, or we can do what's called a lipoaspirate. So in certain parts of the body where there are fat deposits, we will suck out that fat. We will then use that fat, we'll isolate the stem cells, and then we'll culture expand those stem cells. The fat has a benefit in that there's a lot of stem cells in the fat. The issue with fat is sometimes those stem cells are more mature stem cells, so they cannot undergo so many divisions. And they're very good for aesthetic applications and for other types of applications, but for some other applications, sometimes the bone marrow, which is the other big source of stem cells, is a better option. Now, some people are a little bit hesitant to use bone marrow because it can be sometimes painful if the technique is not done properly. Now, I've done more than probably 3,000 to 4,000 bone marrow aspirations, and if the technique is done properly and you do local anesthesia done well, it's not very painful, and patients usually don't complain about the pain doing a small bone marrow aspirate. So this is a typical kind of chart of showing how cell lines differentiate. This is of course, hematopoietic stem cells, and you can start with the multipotent hematopoietic stem cell. And of course, it goes into the myeloid and lymphoids. And of course, you know that the different myeloid precursors, which will of course become RBCs, mast cells, and then different white cells, right? And the different white cells, of course, basophils, neutrophils, and eosinophils. And of course, you get megakaryocytes, which can become platelets, right? So that's your myeloid precursor stem cells. And we use this, of course, stem cell harvesting, and we use this to treat different diseases, and we'll talk about which ones. Now, this is a very important cell line, the lymphoid cell line. And why is it so important? Well, the natural killer cells, which is a very important subset of cells, you should know that in the human body, you are continuously producing certain types of bad cells. And normally you undergo apoptosis, or if the cell line doesn't kill itself by apoptosis, then these natural killer cells are the ones which will go and kill those abnormal cells. And sometimes, for example, precancerous cells. So in the average adult human being, you get 50 to 70 adult precancerous cells being produced every day. And if those cells were to go out of control and not get killed, you would get cancer. Now, of course, these natural killer cells recognize those abnormal precursor cancer cells and then will go and eliminate them. And so understand that at any time in your body, in an adult, your body's fighting cancer all the time. You have cancer cells inside the body, and those natural killer cells are recognizing them and doing reconnaissance and then killing those cells. And also the T lymphocytes and B lymphocytes, which are also involved in the immune system, can produce different antibodies and different other compounds, like your cytokine compounds, which can also cause immune reactions and also kill cells which are recognized as non-self or recognized as abnormal. And we'll talk about this, how stem cells affect this. We call it immune modulation therapy. So there are certain diseases, for example, autoimmune diseases, which we can treat with stem cells, and we'll talk about that in more detail later on. But this is going to be very important to remember your cellular and humoral immunity and how it works and how it's controlled. So, of course, we know that for some certain types of cancers and leukemias, bone marrow transplants and really stem cell transplants were used and are continue to be used frequently, where you can eliminate the producing cells and you have a transplant before, and then you can put the transplant in, and then at that time those cells will start to regrow and you can get your lymphomas and leukemias sometimes cured. Now, certain autoimmune diseases have been treated with hematopoietic stem cells, including rheumatoids, lupus, diabetes, MS. And so, of course, we know in autoimmune disease, what happens is really there's something what we consider molecular mimicry, that some kind of compound is entered into the body. Often we assume a virus or some kind of infection, where the body recognizes that cell as abnormal, but the proteins on that cell are very similar to the body's own cells. And because they're very similar, after the body gets rid of the invading organism or invading chemical or virus, at that point, it also starts attacking the body because it starts recognizing other ones that look like similar. So it starts attacking the bones, or starts attacking the immune-producing cells, or it starts attacking the insulin-producing cells in the pancreas, and then you get these autoimmune types of diseases. Now, this is another source of stem cells, and this is another one that we're using more frequently now, is called umbilical stem cells. So umbilical cord stem cells are another type of cells that we can use. Now, the benefit of umbilical cord stem cells are that, first of all, there's a huge number of stem cells in blood, in the umbilical cord blood, so 100,000 stem cells per ml. The benefit of these stem cells are that while these are an adult stem cell, they're from infant origin, and because they're of infant origin, they don't produce the proper immune type of particles on the outside of the cell. Now, if we've heard of, you guys may have heard of MHC1 and MHC2, your major histocompatibility antigen. Now that, or major histocompatibility complex, that's what recognizes if a cell is foreign or not foreign. So if you take blood from somebody who's not the same type and the wrong person, your body will recognize this cell as foreign, and it will start to kill that, and you'll get, of course, reactions to those cells, what we call graft versus host disease. And so these cells, these stem cells from umbilical cord, don't have those major histocompatibility origins or complexes being produced. And so these cells can do what's called allogenic transplant. So autologous transplant is when you transplant your own cells back into you. Allogenic is when you transplant cells from one individual into another individual. So with umbilical cord stem cells, we can do allogenic transplant. So we can take these umbilical cord cells, and I can take them and implant them into any individual. So cord blood, some people bank it for their own families, and cord blood can be used for other people, so for allogenic transplant, which is very important. So this is why cord blood is often used in certain stem cell transplants, in that it doesn't have the MHC complexes, and so it can be used from one person to another, and that can be shared. Now, different stem cells that we were talking about, where are stem cells located? So in the basal cell layer, the basal layer of, this is a typical slide, the basal layer of the trachea, you have these stem cells which are here, which then can differentiate and become secretory cells or ciliated cells for protection, or even goblet cells for producing mucus or serous mucus. And so these stem cells originate here down at the basal stem cell layer. And that's where airway cells are. In different organs, for example, the intestines, we talked about intestinal as being intestines are where stem cells or cells actively proliferate very commonly. And these are often in the crypts. So at the bottom of the crypts, you have these stem cells. And these stem cells then can be go up and divide and become intestinal villus cells in all the different organs. As you know, the biggest endocrine organ is the small intestine. You have enteroendocrine cells which produce different hormones. And we now know, of course, that the intestinal system and the gut is a very important hormonal system. In fact, all the same hormones that are secreted in the brain are also secreted in the gut. And we now talk about the neural system of the gut, and we talk about how important the gut is, and this is important in FMT and other types of therapies. But of course, the gut is a layer, and the intestines are layers where there's cells actively being produced quite commonly and quite actively. And so these intestinal stem cells can then become different types of secretory cells or absorptive cells or endocrine cells or different types of differentiated cells. So we're talking very little bit about cloning. I will go into just a little bit of detail. Human cloning, of course, there's some rumors about human cloning going on, but it's illegal throughout the world. And we can talk about cloning of embryonic stem cells. Now, we're going to talk about induced pluripotent stem cells. This is very interesting. This is where we take an adult stem cell and we convert it back to a pluripotent stem cell. So we kind of, a stem cell which is already fully differentiated, and we reverse time, basically. We reverse the cell to go back to its original stem cell lineage. So we that chart that I showed you with the blood, we reverse the cell. We have to take a differentiated cell, we turn it backwards back into a stem cell. And this has been done. Now, cloning, of course, is something that has been done with sheep, and it's very famous. And even now, other embryos have been done. difficult to do, illegal on humans, but we'll talk about how it's done and cut and paste of genetic theory. So this is how we do it. You take a cell layer, you have a certain gene that you want to be in the new embryo cell. You take that one gene and the other gene, gene 2, and you can splice them. And once you splice them together, now you have a new DNA which has the different genes together. You can now take that and you can insert it into a cell line. And then that cell line, now when it divides, will have both genes inside and will have the same DNA. So the daughter cell here will have the same DNA as the mother cell. Now, this is how it's been done before. So what we take is we take the oocyte from whatever kind of embryo, for in this case, sheep. You take out the 1N DNA, remove that, and then place in somatic DNA. So this is a 2N DNA. Put that in the oocyte, and then the oocyte will then replicate. And then from there, you can then implant that into a blastocyst. And then once that blastocyst will start growing, then you can take this blastocyst and put it in a surrogate female. And once it's inside the surrogate female, it can grow into a cloned replica, cloned of whatever these cells were. So this is how cloning works. This is called somatic cell nuclear transfer, SCNT. So this is where you take somatic cell nuclei, put them into these non-somatic cells, oocytes, and then you can develop and produce clones. Now, there are some people who are talking about using cloning therapy to produce organs, or producing non-viable, or using organs and producing organs for transplant. This has not been done yet, but people are talking about it. Just so you know, there are ethical issues, of course, with this. Now, this is a very famous treatment, and if anybody who's in stem cells will know this name, Dr. Yamanaka, and with his colleague, Dr. Takahashi, they did induction of stem cells from pluripotent stem cells from skin cells. So they took skin cells, they did these certain genetic programming factors, also called Yamanaka factors, and were able to take somatic cells, which are differentiated cells, skin cells in this region, and turn them back into stem cells, or proper pluripotent stem cells. So now these stem cells were again able to undergo multiple differentiation. Even though they had started off as skin cells, you could now take these skin cells and make them into cardiac myocytes, or turn them into intestinal cells, or turn them into liver cells, or turn them into other cells. So this is called iPSCs, induced pluripotent stem cells. Very important. It's been used now. So these Yamanaka factors are used to produce these stem cell layers, and you can then produce these iPS cells. Now, of course, there's a lot of science behind it. It's very complex stuff where certain genes have to be turned off, other genes have to be activated, certain parts of the DNA, the telomerase ends have to be activated. And of course, all these things have to be done through these Yamanaka factors, and then you can produce these iPSCs. Not easy, but it's taking these somatic cells, which are differentiated cells, and eventually producing these induced pluripotent stem cells. And you can see there's lots of different steps. I won't go into all of these, but all these complex steps, not an easy process, but something that's very interesting and has been done now for patients even. And in fact, a lot of famous VIPs and athletes and stuff are now banking their stem cells. So what they do is they'll do a skin biopsy. They'll take that skin and they'll bank it and put it in a tissue bank. And then so when that person, for example, a certain elite athlete needs chondrocytes or needs muscle cells because they have an injury, you can then take those induced pluripotent stem cells and then convert them into a muscle cell or a cartilage producing cell and then re-implant them into that person. This is also used for drug, and pharmaceutical companies are using this a lot for taking iPSC. So what they'll do is they'll produce certain types of cells, and then instead of having to test on humans, you've now produced those cells in a culture, and you can test your drugs on that culture instead of testing on humans. So this is where precision medicine, or as we say, personalized medicine is in the future. So many pharmaceutical companies are doing this. In fact, on some of the, during COVID, certain types of cells were iPSCs, and they were used to test medications and test the vaccines also. So also very important. And also test the viral infection. iPSCs, of course, now have been done in many different species, and I don't think we need to go into that, but nonetheless, you know that this can be done, and these different species also can be used for drug testing as well. So even animal testing we don't have to do, we can do it on certain cells and cell lines. So the benefit of iPSCs is you don't need to have embryos. You can differentiate into many different cell lines. There's no limitation as far as number. You can keep them renewable. And then you can use and make many different stem cell lines, including blood cells, keratinocytes, fibroblasts, hepatocytes, can all be used. All these different cells can be used to make iPSC. So we don't have to use just skin cells. We can use blood, we can use liver cells, and all of these can be done through IPS techniques and turn from the somatic differentiated cells through those reprogramming factors, through the Yamamoto factors, into iPSCs, and then we can use for either drug screening, drug modeling, disease modeling, or patient-specific therapies. So this is kind of the future of stem cell therapies, and you'll hear more about this in the future, I think, soon. Now, this is something that you need to know some of the terms of stem cells and what's important about stem cells. So we used to think that stem cells exerted their effect by directly transplanting it. So if we would take stem cells, inject in somebody's knee, those stem cells would go right into the area where the damage was and kind of repair the damage. We know that's actually not the case really now. The stem cells, some cells will sometimes transplant, but the stem cells don't often transplant. What happens is more that they induce certain factors, or they create a niche. And this is what the niche we talk about. And there's either direct contact of the cells with the stem cell with contact other cells, or there are certain factors that can produce, or there's an intermediate cell that can be produced. So what happens is that the stem cell exerts an effect in that niche, that microenvironment. So stem cells, when we inject them, their effect is sometimes so they will exert this effect. So the stem cells actually exert an effect through different factors that they produce. And so it's through those factors that the stem cells can turn a different cell. So for example, in certain cardiac cells, and when you inject stem cells into the coronary arteries, or you inject stem cells directly into the muscle, they convert non-myocyte cells into producing and becoming cardiac myocytes. So that's how stem cells really work, is indirectly. And of course, stem cells can do different things. They can convert into different cells, and then you can expand those cells. Now, of course, some cells are more difficult to expand, and you use markers to tell, so you can tell which cells will become neurons, which cells will become blood cells, based on those CD markers. And then you kind of expand them. And of course, some cells are difficult to grow, and other cells are more easy to grow in culture. And sometimes some cells require scaffolding. So sometimes some cells will not grow automatically without some kind of some kind of biogenic scaffold. So often what we call the extracellular matrix, or your fibrous matrix that are in different tissues, the cells need that fibrous matrix to grow on. They cannot just grow on a simple cell layer. So sometimes scaffolding is required. And then different delivery devices we can deliver from a venous side, direct puncture, direct arterial side. For example, there's a big study going on in Stanford right now for stroke patients, where they take stem cells and neurosurgically open up the brain, and then the area which is damaged, they inject stem cells. And it's working, and there are some patients who are getting function back, even motor function back, which is probably the more difficult. Sensory function is more easy to get, motor function much more difficult. We can also inject stem cells intra-arterially, and that's where I kind of come in, where I can inject stem cells through the arteries, through catheters, and we already regularly go through with catheters into the brain, into the heart, and different tissues, and we can inject stem cells. So I've injected stem cells in the brain, I've injected stem cells into the pancreas, we've injected stem cells into the liver, and really that's the way, the natural way of injecting stem cells is through the arterial side. That's where stem cells normally come from, is from the artery side, and they're delivered from the arterial side. That's why arterial therapy, but more difficult to do, but probably more effective than venous therapy. In venous therapy, when you inject stem cells intravenously, the majority of stem cells get caught up in the lung. And we know this through fluorescent imaging, where stem cells are labeled, and the stem cells do get caught up in the lung. Some cells will go through the lung, but the majority get caught up. Of course, the soluble factors that the cells secrete are still secreted, so they still have an effect. But of course, the intravenous effect is not always as strong as the direct arterial or direct injection effect. These are some kind of pictures just for interest's sake, where people have created different body parts like the nose or the ears, and then replace them in patients who've had losses due to whatever, either injury or cancer. Of course, this requires an extracellular matrix, right? You have these fibroblasts that are growing on this cartilage exoskeleton need a scaffold, and that's what we talk about, the scaffold, the cartilaginous scaffold, or other scaffolds that are in the body that you grow then on top of. This is interesting, talking about scaffolds. This is a plastic scaffold that was used. So this was a patient who was born without a trachea herself, this young child, and so they produced a trachea with plastic fibers, And all these plastic fibers, they also grew the cells. So then they made this culture of cells, grew them on top of this, and were able to create or reconstruct some type of trachea, and that was reimplanted surgically into this child. Now, there were some ethical issues with this doctor and other things that he did, and unfortunately, the patient did die. But this is kind of the future of what we're going to do, where we can recreate certain parts and certain tissues in the body through the use of stem cells and through the use of scaffolds. And this is where 3D printing probably will become very important in the future, where we do biological 3D printing, and through biological scaffolds that we can create through biological compounds, we can create these scaffolds and then reproduce them and then put the cells in. So eventually, we know that the Israelis have already created a small mini heart through this process, and we're working on making a mini kidney. So eventually, hopefully, we can grow certain organs. So transplant maybe something of the past, where we actually take and we start growing organs, and when we can transplant those organs in. But again, the scaffold is very important to be able to put those stem cells on. Heart function is very important. So, and heart function, of course, we know that since cardiovascular disease is the #1 cause of death, of course, a lot of research going on with heart cells, and there are stem cells in the heart, and those cardiac stem cells have this certain markers, c-KIT and the SCA, and those stem cells can then become endothelial cells, or they can become cardiac myocytes. And again, when we inject certain stem cells inside, we can actually take them. And we know now with heart failure patients, where we've been very successful, where we can take a class 4, there's a AHA or NHOYA class 4 heart failure, and turn them into a class 3 or even a class 2 heart failure. So we can improve heart failure for certain patients that are in that disease. Now, I will say with coronary artery disease, it's still a more complex process, and we are still working on it, but we're still not there yet where we can actually just do a stem cell injection automatically. Now, I will tell you, there are other things that we use in adjuncts to stem cells, and you may have heard of photobiomodulation or laser therapy. So we've actually done this with certain patients, where we've had a patient who, after a severe cardiac MI, after a left anterior descending blockage, where patient's ejection fraction dropped to about 15%, with stem cells and with laser therapy, we were able to take their ejection fraction, bring it back up to about 50 to 60%. And this has been done with patients. So this is where there are adjuncts to stem cells like photobiomodulation laser therapy, which can be done, which we can activate stem cells. And this also be done in the bone marrow. So if you shine certain infrared laser light on the bone marrow, you can actually activate, and you can get those stem cells to marginate. So those stem cells will leave the bone marrow and become active. And we can actually, with laser therapy, and this has been done in Iran now, because they don't have access to all the pharmaceuticals because of sanctions, they've been doing this where they take these stem cells, they can convert. So you have circulating stem cells a certain amount, you can measure them. And when you do infrared therapy to the bones and bone marrow, you can increase your stem cells in the circulating blood from anywhere from 6,000 to 24,000 times. So this is something else that's very interesting, that laser therapy, light therapy, can also help with stem cell activation, stem cell propagation. Now, of course, strategies to repair the heart, this is where it becomes difficult. Now, I'm going to talk about this, and this is not mentioned here, but this is what exosomes are. So stem cells produce exosomes, and you'll be hearing about exosomal therapy as probably the new future. So as I said, the stem cells don't work by actually transplanting themselves, but by producing certain factors. And those factors are produced by the Golgi apparatus, and then they're packaged into exosomes, and then exosomes are released, and the exosomes are a lipid bilayer. And so those proteins that produce those exiting communication proteins are what cause the stem cells to actually produce their function. And so now we're able to actually isolate exosomes. So we don't have to always have to inject stem cells. We can actually inject exosomes. And exosomes are amazing in that they're very small, so they don't get trapped in the lung. So then you can inject intravenously. So exosomes, which are the stem cell component or the stem cell factor, we can actually take these small molecules and proteins and inject them into different parts of the heart or even other organs, and the exosomes will have their effect. Of course, tissue engineering is something where you need a scaffold to do, and of course, reprogramming, we already talked about, where you can reprogram through stem cells, changing non-myocytes into cardiac myocytes, and you can replace. So instead of the body, which normally, if there's damage to the heart, produces scar, you can reproduce cardiac myocytes again, which will again be functional. Now, this is some of the things that have been done, of course, with type 1 diabetes. We know that we are able to make insulin making beta cells. The problem is that you have to keep on replanting the stem cells. Often they produce insulin for some time, but then they stop producing insulin. This is one of the problems. We have not really been able to control or cure type 1 diabetes. The initial Alberta experiment was done in the liver, where they inject into the portal vein, in the Alberta protocol, and they had about 8 patients who were able to produce insulin for some time. But again, all of them eventually stopped producing insulin, and that project was not able to be reproduced very well. So we know that it is difficult. Certain cells, while you can make the cells again, the ability of the cells to continue functioning is something that's often, for whatever reason, inside the body, there's something that's preventing it from the functioning to continue to be functional afterwards. So while we can implant cells and make insulin-producing cells, they don't always stay productive for their entire lifetime. In fertility, this is very important, and this has been done now with ovaries and also with spermatocytes. You can actually produce with stem cells. You can inject these directly into the ovary, and you can get ovarian tissue to produce new eggs. So this is probably one of the reasons, one of the new ways to treat infertility will be direct injections. We're doing this now already, where we inject the ovaries, or we can inject the testes, and we can induce stem cells to differentiate and then produce either spermatozoa or oocytes. Some trials have been done for some of the neurodegenerative changes and neurodegenerative diseases, and we'll talk about that later. So, of course, there are many reasons for using stem cells, of course, for grafts and treatment of disease, for organs that are not available for transplant. Anti-aging has become a big reason that people come to us for stem cells. We have a lot of clients that come to us specifically for anti-aging, and they want their cellular age, while they may be in their 60s or 70s, they want their cellular age to be in their 20s. And we can do that to some degree. Gene correction with CRISPR technology you may have heard of, and there are some labs that are doing that now, and of course for drug delivery. This is, again, we're talking about the scaffolding. This is very important. This is why sometimes certain things we can produce, certain things we can't produce. The scaffolding has to have certain structural components. It has to maintain its shape. It has to have certain coating, chemistry, not rejected by the body, not toxicity, rigidity and porosity, allowing the cells to graft onto the structure. And then, of course, the way that a cellular microenvironment is also very important, that the cells will adhere and they'll improve these integrins and other extracellular matrix so that the cells stick together and continue to grow. Can be done, but it's not that easy. There are certain chemical growth factors like EGF, FGF, and these TGF, which are used to produce those stem cells and produce them on an extracellular matrix or scaffold. And then, of course, delivery of the cells is often something that we have to see. And this is what we're talking about 3D printing and computer-aided design, where you produce certain extracellular scaffolds, and then you can put the cells on top of them and allow them to grow. I guess this is being done already now with vessels and other things where certain antibodies are produced, and you can then put these surface cells on top, and then they will produce endothelium. Now, of course, there are some controversies, and some people in the religious community believe that stem cells and these kind of things should not be used. I think that Allah has given us, the way I think about Allah has given us the technology to do certain things, and of course we should not do any unethical things, but if we can help people cure and relieve their symptoms and problems, I think we should try to continue doing that. These are some of the controversies that were talked about. I'm not going to go into the detail in this, but I'll tell you that some of the Far Eastern countries have actually changed some of their restrictions on stem cell cultures and stem cell lines, and what can be used and what can be done in therapeutic cloning versus reproductive cloning. And they're kind of ahead, and probably Singapore is one of the countries which is very far ahead of the curve as far as their laws and regulations. And this is the Indian guidelines also. We talked about some things being permissible and not permissible, and doing things with certain spare IVF embryos. Anyways, the point is that there are some ethical issues when we start doing stem cell work and stem cell research. And this is just little cartoons, kind of things, just to think about. And so I don't want to go into all the details. I do this for a classroom, sometimes discussions talking about, we just do discussions for students to talk about what do we do ethically and what should we do and how things can be done and things, but it's just something to think about in the future. And of course, this field is still very much in its infancy, and inshallah, with the will of people and good funding, we will continue to start hopefully improving and curing certain types of diseases. And that's it. That's the final slide. I hope that wasn't too much basic science and too much cellular biology.
Thank you so much, Dr. Husnain. Really, it was a brainstorming session, and so many hopes and so many beautiful things were there. And before we start the question answer session, I will request any of you if he can add something in the discussion after Dr. Husnain.
Yeah,
Anyone?
Assalamu alaikum. I'm Dr. Lukman with here, and
Yes.
it was really enlightening to hear.
Welcome.
Yeah, how is it? I'm obviously first time listening to Dr. Muzaffar, and it was really an enlightening session, and his talk was very profound, and I really enjoyed it thoroughly. But what I was thinking about was about the cancer therapy. I would like his view about the cancer management, where
Yes.
he sees this stem cell therapy, and not talking about the hematological aspect. I'm talking about the solid cancers.
Yes.
Where does he see moving
You're right.
forward in that?
Yeah, so you probably heard of CAR-T therapy and the CAR-T T-cell therapy. So remember, if you remember that picture I showed you of the hematopoietic stem line, you can produce natural killer stem cells in the lab. So let's say you have a cancer cell, solid cancer. This is where with solid tumors is where this is being used. You can take a solid tumor, you can bring it out, you can have the different antigenic factors of that tumor being produced, and then you produce natural killer cells which will naturally attack those specific antigens only and not attack normal cells. So what you do is you produce, and you can do this in the lab, where we can produce a huge number, billions of natural killer cells, which are now specifically targeting only the cancer cells. So, and then you can re-inject those back in the body, and you can even re-inject them sometimes around the tumor, intra-arterially around the tumor. And what will happen is those natural killer cells will now kill the tumor cells, and specifically just selectively the tumor cells. So you don't get any of the side effects of chemotherapy, which is, a shotgun blast. You're getting very precision therapy for cells. And I think this is the future where this CAR-T therapy and natural killer cell therapy for tumors is going to be the future, because that's how the body, as I said, your body is producing precancerous cells every day, 50 to 70, and those natural killer and T cells are the ones that kill that cancer anyways. So this is just harnessing that power and using it to aim it at specific tumors which have become kind of outgrown and are very big.
But I was interested to know, do you have any idea about the management of the cancer stem cells? Where does this science has moved forward? Where exactly is this science in the management of solid cancers, the cancer stem cells?
Yeah,
where
so,
are we right now?
Cancer stem cell.
Okay, so you're specifically speaking about cancer stem cells, where the cells who become cancerous. Yes, very good.
Yeah.
So so this is not my field specifically, but and I do a lot of oncology work as an interventional oncologist, but interventional stuff. But so the cancer stem cells. So yes, there's a lot of study right now going on which cells become cancerous and how certain cells become cancerous stem cells, and what are the factors which do that. And so there is a lot of studies being going on where they're doing certain types of monoclonal hybrids, where they have these hybrid cells, and then they produce these into cancer cells. And then those cancer cells, then you'll arrange, or you'll have different agents to attack them. I will say my knowledge of cancer stem cells is still somewhat limited. I know some of the people who are doing it, I know some of the labs that are doing cancer stem cell work, but my work is not so much in that. But yes, knowing how those cancers, how certain cells become cancerous stem cells, how to stop them is really the key in stopping cancer. And I think
the recurrence,
yeah, especially for recurrence, because a lot of cancer stem cells become resistant to chemotherapy, and how that resistance develops and how to attack that resistance is going to be very important.
And the other thing I was thinking about was the liver.
People to raise their hand to ask the question. If they want to ask the question, definitely there are some cells in the cancer where we have requested a Nobel laureates who will discuss on this, the cancer therapy of the stem cell. Dr. Azra Raza from the Columbia University. Next week, we are requesting him. And no doubt, this is the time very, very soon we will say the goodbye to the chemotherapy, we will goodbye to the radiation, because there are so many stem cells present in the cancer who are protecting, who are acting like CD34, CD24, CD117. Anyhow, this is another topic. But today we are discussing some regenerative medicine, and you can ask the question related to regenerative medicines. Dr. General Aslam Sahab.
Sir, thank you very much. Dr. Shah, very illuminating talk, which was introductory to stem cell therapy. I wonder these days the literature is very much inclined to have regenerative therapy by stem cells for the endocrine pancreas to relieve the endemic of diabetes mellitus. What are your comments on it? How much progress has been made in this direction? Please.
Yes, so very good. Yes, excellent. And so, as you know, with type 1 diabetes, which is more of an autoimmune disease, we've had some more success in producing beta cells, which can produce insulin. And we're putting them, and now we are able now to do intra-arterial injections into the pancreatic arteries. So we've done this now. We've tried this where we've injected stem cells, specifically stem cells, which will produce or help produce insulin. We've done that with type 1 diabetics. And we're getting, again, as I said, the problem often is that you'll start producing insulin, but it will not become your basal level of insulin where you can actually treat the patient and you can put them on exogenous insulin. This is the problem. You will produce some insulin, but you will not produce sometimes enough for the patient to be off their insulin meds.
I will request to mute people because we are not understanding the answer of the speaker.
Now,
Please
for type 2, for
mics.
type 2 diabetes, as we all know, type 2 diabetes is really an insulin resistance problem and
Yeah.
not so much an insulin producing problem.
Yeah.
Insulin does stop producing after some time, but it's really the resistance to insulin, which is the problem. So in type 2 diabetes, we are trying to also induce and try to, in the body, change the muscle cells, because the muscle is often the biggest component where insulin is reproduced. So if we can produce muscle, and we have certain, with certain chemicals now and with certain stem cell, we can inject into the skeletal muscle and produce new types of muscle, which pulls in a lot of insulin and allows insulin to be used and then decrease blood glucose levels. We've also found that that's helpful. But again, I think, unfortunately, type 2 diabetes is a little bit more difficult to treat in that because it's really a multi-system process where the insulin resistance happens, and it's not just where we can just take some cells and put them back in. But I think in the future, there will be a lot of hope for our type 2 diabetics also, in that we can start at least getting them off some of the more medications with side effects and make them produce some more insulin and make that insulin less resistant to use also.
Right. Thank you very much. Thank you. Thank you indeed.
Professor Dr. Iqbal Hussain Dogar, Principal, Gujranwala Medical College. Professor Dr. Iqbal Hussain Dogar.
Thank you very much, Professor Muazzam Bukhari, and a really nice presentation by my friend, Dr. Husnain Razad. Dr. Husnain, I want to ask one question. Whether you are a neurointervention radiologist, whether you have some experience of injecting the stem cell ependymal cells for the paralysis patients, either due to some congenital disease or some acquired diseases?
Yes, very good question. So we have been doing for patients with spinal cord injury. Now, this is with patients with incomplete spinal cord injury. Now, complete spinal cord injury, the problem with spinal cord injury is that when the spinal cord gets injured, scar tissue or glial scar tissue develops very quickly. And so you either, if you are going to inject stem cells in those patients, you have to inject them very quickly and usually intra-arterially. So we have done that for certain spinal cord injury patients where they have paralysis, so either paraplegia or even quadriplegic patients. We've got sensory function back very quickly. Motor function, on the other hand, is a little bit more difficult to get. And what we've seen for motor function, sometimes you need some kind of stimulus. So what has been done is injecting stem cells into the spinal cord and at the same time doing electrical stimulus through a spinal cord stimulation device. So that what we see is that the combination of both putting the cells in and then also providing a neural stimulus allows those cells, the axons, to regenerate and allows the dendrocytes, oligodendrocytes, to regenerate their different connections. So then the nerves become functional. Now, for specific paralytics, we've done it in some patients, and we are doing some CRISPR technology for your myotonic dystrophy patients and MDS patients and stuff. And this is being done. There is some good potential, especially for CRISPR technology, to actually remove the defective gene in multiple muscular dystrophy and put in an actively producing gene, which produces normal muscle. So this is being done, and inshallah, I think we'll see more and more successes in the future. But as I said, this is still developing, and we know with certain types of paralysis, it's not easy. But the thinking that neurons cannot regenerate, that has now changed. We know that we can regenerate neurons. It is possible. Before, we were taught in medical schools, neurons, once they're dead, they're always dead. That's not true. We can actually regenerate neurons.
Thank you. Dr. Professor Rafiq Kanani.
Assalamu alaikum. Thank you very much.
Walaikum salam.
It has been very enlightening presentation by Dr. Husnain Shah. I have got one comment and one question.
Sir,
My question is that there is a hypothesis that malignancies arise due to asthenia of natural killer cells. So, is there any way we can find out is to prevent such kind of natural killer cells inability to reproduce or inability to function efficiently, so that the cancers can be prevented?
see,
Yes.
Dr.
So
Husnain, yes.
yeah, so natural killer cells is a huge growth field where we are doing, and there's lots of research going on, and a lot of stem cell laboratories are producing natural killer cells, and they're actually producing them for patients as an exogenous therapy. So we take their own natural killer cells, we clone them, we culture expand them, and then we can inject them back in the patient. And of course, this is what precision medicine is that you take your own body's cells, which do go and kill bacteria and go and kill viruses and go and kill cancers. You take those and make them active. That's something that's very important. Another thing that's very important, not just the natural killer cells, but on the immune side, is having certain immune factors so you can recreate apoptosis. Remember, your body is in a constant flux between killing cells apoptotically and allowing other ones to regenerate. And sometimes there's a balance. And if you don't allow enough autophagy, as we say, or the killing of its own self or the eating of its own self, autophagy, if the body doesn't allow enough autophagy, that's how we age, basically. When people are aging, you start getting these aging cells that continually are accumulating, and the young cells, because of the aging cells effect, they push the young cells not to grow. Now, we know that the human body, and this is very interesting, the human body, if it doesn't have all these aging and degenerative processes, can grow to about 800 years, which is very interesting. Most of the cells could grow for up to 800 years. We know that through research. So the body is able to do it. The problem is we have to figure out what are the factors which stop us from going into apoptosis and stop our natural killer cells from becoming as active. And that's where certain growth factors and these kind of exosomes will be very helpful in the future.
And my next question is from Professor Mulazim Hussain.
Sir.
That's regarding the ethical guidelines of stem cells research and its therapeutic use in Pakistan.
Sir, we started around about 25 years back this research in King Edward Medical University, and we have trained so many people. Unfortunately, due to some political issues and some teachers unknown and ethical issues, there is still we have not started anything. If we compare Pakistan to the other countries, same when I went in the Dubai and met these peoples, and why I was really strange that how many expanded treatments they are doing, and but in Pakistan still we are wondering this thing. Hopefully, private public sector can shake the hands to produce to start these centers in Pakistan. And also we'll request Dr. Husnain, how can we help you? Can you help any research centers we can start here in Pakistan? As Dr. Imran Abbas has promised that he can help in Pakistan to starting some training centers in the artificial intelligence, because I myself started this program in King Edward Medical University, and we established a stem cell lab. I was the first person in Pakistan to bring this Professor Rafiq Kanani research in King Edward Medical University, but still, unfortunately, there is no progress in this way. Dr. Zola,
can I put in a word?
The
university.
Coming to you, Dr. Salma Kondi, I am coming to you.
Okay.
Dr. Zola Husnain, you have raised the hand. Dr. Zola Husnain. Dr. Zola Husnain is also interventional radiologist in CMH. Dr. Zola Husnain.
Sir, my question is regarding two aspects. These days, liver transplant and hepatocellular carcinoma and chronic liver disease is very common in Pakistan. And I have heard that there are some studies, some centers which are doing some research in stem cell to treat these cases. do we have some prospects in this this kind of disease in Pakistan? Because we are seeing a lot of cases who cannot undergo even transplant because they present very late.
Yeah, so very good question. And as you know, HCC is become a huge problem in Pakistan. And it is a big issue in some of these patients. Yes, they cannot go under transplant either because of some problems with their body, or they have too many circulating tumor cells, or they have extrahepatic manifestations. So they're not transplant candidates. And as interventional radiologists, we try to choose, of course, TACE and TARE and radioembolics and other kind of things to kind of control tumors. There are some, so in the Far East, especially in Japan and China, they're doing some studies with natural killer cells, where again, as I was saying, you produce natural killer cells which are anti-HCC. So you have natural killer cells which you culture expand in the lab, and then you inject them intra-arterially. Now, the problem sometimes with this is, of course, getting enough of the natural killer cells into the tumor bed. And as we know, this is the problem with both chemotherapy and problems with other heat therapy, cold therapy, cryoablation or RF ablation, is just getting enough of the tumor to be exposed. So sometimes you have to do multiple treatments where you have one set of cells goes in, kills a certain amount of tumor, and then you produce more cells, and then again you have to inject them again. But it is being done, and I think unfortunately it is still a problem. I think more importantly will be the ability to regenerate liver. And we know that we can do that also with portal vein occlusions, and we can regenerate, let's say, the left lobe or the right lobe or other lobes of the liver. This is something that can be done, and that the regenerative capacity of the liver is actually very important also. So I think the first step is first remove as much tumor as possible, and really you have to remove it with surgical margins, and then eventually regenerate the liver that's there. And I think this can be done, and I think in the future you'll see some good therapies. But again, the problem is that when the size of the tumor cells becomes too big, or the circulating extrahepatic manifestations are there, then that's a problem for those kind of patients.
Professor Salma Kundi, before you start the questions, you have written any stem cell center in the Pakistan. Yes, there were few stem cell center established in 2016 and 27. One was the Ramzan Ali stem cell, and one was the under the American stem cell at Lahore. And one stem cell center was established at Karachi. But the answer is still they are bringing they are exporting the stem cell from the America, from other areas, and they match the stem cell. But I think there is no proper management, and they are not properly working. So that is why in Pakistan, I cannot recommend any of the center for the stem cell. Even there is a research center in the King Edward Medical University stem cell. Professor Salman Kundi, can you ask something more? Professor Salman Kundi is a principal of Azad Jammu Kashmir Medical College Muzaffarabad, and I am proud with Professor Salman Kundi. We are running this webinar from the last more than 2 years. Professor Salman Kundi.
Thank you so much, Mulazim Saab, and thank you, Dr. Husnain. It was a great talk. Dr. Saab, I only wanted to know, if we don't have any good center in Pakistan, what about the neighboring areas? Which center would you suggest for somebody who is a cancer patient? And then again, for the relatives who have a high incidence of cancer and sort of genetically modifications can be done through stem cell therapy. I'll be very grateful if you give us the name of 1 or 2 centers. Thank you.
Sure. So I would say in our region, and I'm talking about our local region, kind of defined into the countries that are kind of bordering Pakistan and UAE area. I think actually unfortunately, the Indians are very advanced in cancer therapy, and they've done a really great job. Sometimes it's difficult for some of our relatives and people to get over to India. The other country that you'll be surprised to hear, and probably has, so there's a number of publications that are done on stem cells, and it's counted. The US has the number one number because they have the most number of labs, but number 2 is actually Iran. And Iran, and especially Tehran University, and also Isfahan University, and a couple others are very active in stem cells. And the reason, it's because, as we say, necessity is the mother of invention.
Even Shiraz University.
Yeah, Shiraz University too. We say necessity is the mother of invention, because Iran has been under sanctions, and they could not get certain pharmaceuticals, they could not get certain treatments, they could not get certain devices. They started using the ones that they had. And so they are very active in stem cells. In fact, Tehran University publishes a huge amount of stem cell research all the time, and they do a lot of cancer work also. So, and also they're using this photobiomodulation lasers, which have been very effective in cancer. So using stem cells together with photobiomodulation, we've seen that there's a lot of cancers that, I've seen myself some incredible cases where a patient with an 18-centimeter colonic tumor with liver mets, with lung mets and brain mets, normally a person like that, we give them we tell them you will have 6 months or a year to live. I've seen one of those patients now in Iran. He's now alive more than 5 years. Unheard of to have liver, lung, and brain mets and still alive after 5 years, especially with the 18-centimeter colonic tumor.
Dr. Asad Afzal. Dr. Asad Afzal.
Assalamu alaikum ji.
Thank you, sir.
I'm not a doctor. I'm actually a 40-year-old retinitis pigmentosa patient. And I have a couple of questions and a compliment to give to Dr. Husnain. Being a person with absolutely no medical education, your talk was still very informative and I got to learn a lot. My question is, where is stem cell research in particularly if I ask for retinitis pigmentosa patients? Because I've seen a lot of research being done in University of Ankara in Turkey. And my other question is, from the articles I've read and for the literature, what I've seen is that in a year or so, the stem cells injected in the eye stop regenerating. And my other question is, what is APRP? Is that a part of stem cell? Is that a branch of stem cell therapy? Thank you.
Sorry, I'm not sure APRP. I'm not sure what does that stand for?
APRP, I don't know what does it stand for. Basically, what it is it takes plasma out of your blood, and then they inject it in the eye. Doctor in Lahore.
Yes, acellular PRP. Yes, so that's
yes.
Yeah. So acellular PRP is injecting. There's a part of the plasma. So you spin down the blood. You spin it down usually twice. You get the cellular elements out, and you're left with the growth factors. And those growth factors are in that plasma, what we call the platelet-rich plasma, or sometimes we call it platelet-rich factors. And you can inject those factors into different parts of the body. We do that with in the eye. We do that in the. I don't, but there are people who are doing it intraarterially into the eye. There are some ophthalmologists who directly inject it into the eye, and they are able to regenerate certain cells because there's at least 60 to 70 major growth factors in the blood. And those help those cells which are dying to regrow again. So for retinitis pigmentosa, the countries which have probably the most advanced stem cells have a combination of two things. One, they have a lot of government money that's put into the research, and two, their regulations are not as strict. So this is why actually we would think the Western European and American, these people are ahead. Actually, they're probably behind. The countries that are ahead, I would say, in stem cell research, and I'll name them, are probably Turkey, China, India, Iran, and Thailand. And these countries are probably the most ahead, one, because of a combination of the regulations and a combination of the research that's going on and being supported by the government.
So as a patient, if I'm looking to get treatment for retinitis pigmentosa.
Yes. I would think that probably for you, probably either Iran or Thailand and Turkey would be the top three places to consider.
And one last question. I met a doctor over here in Lahore, Dr. Irfan Karamat. He suggested that I should get APRP initially and then go for stem cell, because his consideration was that when APRP responds in the eye, that gives stem cell treatment more higher chance of achieving the goal.
Yeah, so the way I always tell people who are non-scientists, and the way I describe stem cells and PRP, stem cells are like the seed, and PRP is like the fertilizer. When you use the two of them together, you get a much better effect. And actually, the other thing I sometimes add is if you add laser, photobiomodulation, sunlight, or in this case, specific types of light, infrared light, you actually get a much better response. So yes, I think that the combination of using PRP with stem cells is usually a better form of therapy. And if you can combine it with photobiomodulation, as they do in Turkey and as they do in Thailand and Iran, then you might get a much better effect.
Thank you, Dr. Wasik Qazi Saab. Dr. Wasik Qazi Saab.
Okay, thank you very much, Professor Mulazim. It was excellent and very informative presentation by Dr. Shah. Thank you very much for such a wonderful presentation, Dr. Shah. My question is regarding the stem cell banking, because in last few years, there have been families, affluent families, who were, getting their newborn babies, placenta and umbilical cord being preserved for the stem cell banking. People in Karachi, there was a program wherein these people were collecting these stem cells, umbilical cord and placenta, and they said they are going to preserve it in a tissue bank in England, where it can be preserved for decades. And when the family requires that, in their heart diseases or the cancer diseases, once they develop, it can be used there. So how do you think that these tissue banking and the stem cell banking, how many centers are working in the world, and how do you see the future of this stem cell banking?
Yeah, so very interesting and very good question. So stem cell banking has been done for a long time, and it's, as you said, taking from umbilical cord and placental blood and preserving it and keeping it preserved for many years. Now, the issue that is always there is that it's the tissue banks say, okay, we will have your tissue, we'll preserve it, we'll keep it for many years, we'll cryopreserve it, and they are doing that. Now, the number of applications where they actually taken the tissue and then use it again has actually been very few. So it's not a proven technology. It's proven that you can take cells, you can bank them, you can freeze them, and we know that we can use stem cells. But what I would say a little bit of this is a lot of it is salesmanship, and they've been selling these tissue banks in a lot of places, and a lot of people have paid a lot of money for their tissue to be banked. But the practicality of it has not been, I would say, not been completely justified yet through actual examples. Now, there are a few cases where in leukemia and lymphoma cases, those tissue bank cells have been important. But as far as other types of diseases like heart disease, or the major three killers, heart disease, stroke, or diabetes, or cancer, or these type of things, or degenerative changes, degenerative problems have been cured through banked tissue. It's still not there yet. And I think the thinking is that these banks, there's some big banks in London, there's big banks in Dubai, there's big banks in other countries where they've kept this tissue. It's still, to me, it's a lot of hype, and whether it works or not is still up in the air. But they do tell you that they have the tissue. Yes, they have the tissue, they have the cells. Now, taking those cells and then converting them to usable cells still has not always been done.
Thank you, Dr. Zulhasnain.
Yeah, that's a great answer. I think I do totally agree with you.
Dr. Zulhasnain. Okay, there is one question from the Dr. Umar Farooq. Is there any role of stem cell therapy in autistic children?
Yeah, so very good question. Yes, with autism, and we see an increasing incidence of autism throughout the world, where, maybe 20, 30 years ago, it was 1 in 300 children that would have autism. Now we have, in some countries, 1 in 33 children having autism. And I think there's some environmental factors, and I don't want to go into them, but yes, so there are people who are injecting stem cells. They often inject them intrathecally, so into the spinal canal and into the CSF space. And that combined with hyperbaric oxygen and combined with very good nutritional therapy, physiotherapy, occupational therapy, I think the three of the 4 or 5 things together, and also laser therapy, you do get some improvement in cognitive function in autistic children. Can you cure autism? I'm not sure about that. But can you raise the functional level of a child who's autistic? Yes, I think you can. And I've seen some cases where we have children who are completely non-communicative, could not talk at all become communicative and become able to speak and actually have conversations and increase their cognitive and decrease their cognitive deficits. That I have seen in autistic children. But as you know, like many disease processes, autism is not a single gene mutation or a single problem. It's a multifactorial problem. And so it takes a multifactorial approach. But the things that I would say is, yes, stem cells intrathecally plus intravenously, laser therapy, good physio and occupational therapy, these things, and hyperbaric oxygen can combine to produce significant results in autistic children.
Dr. Zulkarnain, last question, because there are so many questions, but due to time problem. Dr. Zulkarnain, as well as
my last question.
Dr.
Sorry
Zulkarnain.
to bother you again and again.
No.
Actually, my question is that this technology and all of this thing is very new. Are there any facilities where our people can go and they can learn these techniques and apply in our country?
Yeah, good question. So, inshallah, we are planning on doing some course and training in Pakistan soon. We have some courses. There are online courses that you can always get. There's the American Board of Regenerative Medicine, the American Academy of Regenerative Medicine, which has an online course. You can learn a lot of the theory, and you can learn a few of the practical aspects of this. I will also tell you, and you have to be careful, there's a lot of stem cell courses that are offered in different countries, and they're just a waste of time and waste of money. They don't really teach you much, and they just kind of take your money and say they're going to teach you stem cells. I think if you really want to learn stem cells, one thing is to take the online courses that are offered by accredited organizations like the American Academy of Regenerative Medicine, or the A4M, which is the Anti-Aging and Regenerative Medicine in the US. They have board certification courses. You can take the course, you can actually get board certification, and then you have to go to a practical center where it's being done and you have to learn. And that's the way that I learned myself also, is take the courses, and then I had some teachers who were able to teach me some of the techniques. And then some of the stuff we've been doing on our own. Intra-arterial work we've kind of started doing ourselves in certain patients in part of a IRB kind of protocol. But yes, I think start with the online with the accredited organizations, and then go into practical training with somebody who's already doing it. I said, as I told you, in Iran, there's lots of opportunities, lots of people who are doing some amazing stuff with stem cells and photobiomodulation, and really they're ahead of the curve. And because we think of Iran, we don't think of it as a huge, kind of science or medicine center, but actually they produce a huge number of publications in stem cells and stem cell research.
Thank you so much, because this is the largest and biggest topic, very important topic. And there are so many questions, but due to time is over, we hopefully, inshallah, we'll continue this discussion. Dr. Zulkarnain, I myself went in the Shiraz University to learn the stem cells. That technology we brought in the King Edward Medical University. In the Shiraz University, there is a center of excellence for the training. Even Dr. Husnain, and where he is working in the Dubai, they are also doing this well. I will hand over today's now over to you, Professor Salma Kundi, or Professor Qazi Wasik Sahab, who is our president of SMAO, and Professor Salma Kundi to conclude today's session.
Thank you so much, Professor Mulazim Saab, and I thank you for arranging this lovely talk. And my special thanks to Dr. Husnain Shah. It was wonderful. Dr. Husnain, you have opened and taught us so many avenues in which we too Pakistanis can learn about stem cell and try to bring it into the country. And I hope the success rate is great. I was only wondering, can't physiologically we reactivate the stem cells within the body by any technique, like you mentioned, the laser? What if we sit in the sun and sort of get the infrared rays? Would it affect it? And
So
walking or any other maneuver?
Agreed.
So
No, it does.
need...
No, definitely. Just being in the sun, especially you want to avoid the hot sun, which is at 12 o'clock or 1 o'clock sun. But if you go in the morning, amazingly, if you go to the Fajr time and you get exposed to the sun at that time, just after Fajr, when the sun is coming out, you get less of the UV, the damaging rays, which are UVB and UVC rays. You get more of you can get more of the infrared and the UVA rays, which do have a positive effect on stem cells. And so just natural light. In fact, there was something called heliotherapy, which the Greeks used I mean, 3,000 years ago, they were using heliotherapy and using it to cure certain disease. And they were, we think now, we postulate that they were actually activating stem cells through the sun. And that does, we know that certain diseases can be cured through sun exposure.
Thank you so much.
Thank you so much.
Professor Luqman, before we conclude, you want to give your comments? Professor Luqman from UK.
Thank you very much, sir. It was, I really was impressed by the topic and by the presentation of Dr. Muzaffar, and it's like an eye-opening, and obviously it gives us a lot of hope, as well as obviously as the other comments have been, that about how to manage diseases in a new fashion and in a new way. And obviously, as my field is oncology, I'm more interested to see how does the stem cell therapy can help patients with solid cancers. And that's the avenue we are looking forward to, that we can stop the process of recurrence and stop the process of, the tumor resistance and so on and so forth, with the help of the modulation of stem cells and also the cancer stem cells. So thank you very much, sir. It was an honor to be a part of your of this webinar, and looking forward to another interesting topic next week.
Professor Luqman, next week is your lecture.
So I am right. I told you I'm in a state of flux right now. I'm somewhere. I'm leaving back to my home. So, but I'm at your service in the month of March. I'll be ready for you, sir.
Okay, in March. Okay, thank you.
Inshallah. Thank you very much, sir. Looking forward.
Wasif Qazi Sahab, can you give last comments? Dr. Wasif Qazi Sahab. Dr. Qazi Sahab. Okay. Madam, can you conclude today's session?
Thank you.
Okay. Can you hear me?
Okay, Qazi Sahab, you do it.
Thank you, Professor Salma Kundi. Thank you, Professor Mulazim, and thank you, Dr. Shah, for excellent presentation. As Professor Salma has pointed out, that today it's a new door opening and a new avenue for us all to think about and to work on it. It was very exciting and very informative and knowledgeable, very scholarly, and I think we should all work on it, and we should have more stem cells centers coordinating with us to develop stem cell research and stem cell therapy avenues in Pakistan. It was excellent. Thank you very much. Thank you all who participated.
काजी साहब, इससे पहले कि आज खत्म करें हम, आपने इनका डॉक्टर हसनैन का आखिरी स्लाइड दोबारा देख लें कि बुढ़ापे को जवान करने के लिए स्टेम सेल की जरूरत है.
बिल्कुल सही है. और ये हम बूढ़ों के लिए बहुत ही हौसला अफजा चीज है. We really appreciate that. मेरा ख्याल है कि जिंदगी को और अच्छा और बेहतर बनाने के लिए डॉक्टर शाह ने आज सबके जो है ना वो कान खोल दिए हैं, और हम बड़े ओपन माइंड के साथ we are thinking on it कि हम मल्टी सेंटर्ड courses और इसके ऊपर lectures कराएं. We'll invite in Karachi also Dr. Shah to come over, and PMA will definitely coordinate and will have opportunity to listen to him, और यहाँ पे कोई centers को हम activate कर सकें. Thank you very much, Mulazim.
Thank you very much, Dr. Husnain. Thank you very much. Really, inshallah, we will invite you.
My pleasure.
Another lecture, interventional therapy for the neuro shock, stroke.
Sure.
Thank you so much. Thank you so much. Allah Hafiz.
Thank you, Dr. Husnain. Thank you. Allah Hafiz, Mulazim sir.
Okay, Khuda Hafiz.
Have a good day, everyone.
Thank you. Thank you.